and have been asked to talk about controversial issues in venous disease. I have no disclosures. Well, the explosion of technology in venous disease has led to the application of a number of these technologies in patients without a lot of data to back it up in many cases, with the result that there's a number of very controversial issues in venous disease. This is supposed to be a 9-minute talk, and it's unfortunately impossible to talk about all of these. But I've listed a few of the controversial areas I think are important in an acute venous thromboembolism, in superficial venous disease, and in deep venous disease. And I'm going to concentrate on one from each of these areas since we don't have time to talk about all of them. The first area I'm going to address, which is a very controversial issue, particularly in the United States, is the interventional management of submassive PE. Now, the American Heart Association recommends that we stratify patients with pulmonary embolism into these 3 categories associated with their underlying risk of mortality, which ranges from 30% in those with hypotension or so-called massive pulmonary embolism to 2 to 5% in those with lesser degrees of pulmonary embolism. And the treatment of these has been fairly well validated in the literature, with the treatment of massive PE being appropriately treated with systemic lytics and non-massive PE with anticoagulation. But the submassive category remains controversial, and this is defined as those patients who are normotensive on presentation but who have evidence either myocardial injury or right ventricular dysfunction, either on CT, pulmonary angiography, or on echocardiography. And this group has been proposed that there may be a role for the routine use of catheter-directed lysis in these patients. Well, what data is there to support this? And really, the only recent randomized trial was the PITHO study that was presented at the American College of Cardiology in 2013. This was a very large study in which over 1,000 patients with submassive PE, again defined by either myocardial injury on laboratory tests or right ventricular dysfunction, were randomized either to weight-based tenecteplase administered IV, not catheter-directed, or to placebo plus unfractionated heparin. And you can see mortality, or the primary endpoint was not mortality, but was a combined endpoint of all-cause mortality and hemodynamic collapse within 7 days. You can see there's a 56% risk reduction in this primary endpoint, with a reduction in the primary endpoint from 5.6% in those treated with placebo to 2.6% in those treated with the lytic group. But you have to look closer, and quite a bit closer, at this data. If you look at the endpoint, which was this combined endpoint, it wasn't driven by mortality, which was really no difference between the 2 groups at significantly less than 2%, but was driven primarily by this hemodynamic collapse category with hypotension or the need for pressor support driving it, but with no difference in mortality, and at the expense of a 6% rate of major bleeding and a 2.4% rate of stroke. If you look at this closely, this is hardly a positive trial. There's no mortality benefit. The number needed to treat, that is the number needed to prevent 1 case of hypotension, was 29 patients, while the number needed to harm, that is the number that you had to treat to cause 1 stroke, was 45 patients. Pretty well balanced, but the harms, I think, outweigh the benefits in this case. Well, what about catheter-directed thrombolysis? In the United States, anyway, this has been largely driven by industry with ultrasound-accelerated thrombolysis without a lot of data to support it. Clearly, it does have a potential for more rapid lysis, more complete lysis, and lower lytic doses, but much higher costs associated with it. And the only trial that's been published to date was the ULTIMATE trial, which failed to look at any clinically relevant endpoints. They didn't look at mortality or anything else. They looked at improvement in echocardiographic parameters, particularly in the RV to LV ratio. These patients with submassive PE, and there weren't very many of them, only 60, were randomized either to unfractionated heparin or to ultrasound-accelerated lysis using the ECOS device. And the results showed very few complications, much fewer than in systemic lysis, but not a lot of benefit. There was a significant benefit in the reduction in the RV and LV to LV ratio at 24 hours, as shown there, but there was no difference at 90 days. So this was a short-term benefit with no demonstrated benefit on mortality. And I think this issue remains unresolved and really requires appropriate trials with appropriate clinical endpoints. There may be fewer complications, and I think it probably is appropriate in highly selected patients, but as a routine management strategy, I don't think this can be applied until we can demonstrate a mortality benefit or long-term benefit from this. The second controversial issue, which was touched on in the last talk a bit, was sclerosant gas composition. Ultrasound-guided foam sclerotherapy is now being widely applied to a large number of problems, including reflux within the saphenous veins and their tributaries, to venous malformations, as well as pelvic venous congestion, classically prepared using the Tessari technique with aspiration of sclerosant, of detergent-based sclerosant, with either air or CO2 through a three-way stopcock. Probably the best series looking at the complications of ultrasound-guided foam sclerotherapy is this one from France. Over 1,000 patients who were followed prospectively. They showed very good results as far as elimination of reflux, and complications were rare. About a 1% incidence of venous thromboembolic complications, about a 2% incidence of neurologic complications. No strokes in this series, although 3 have been reported in the literature, 1 TIA, 8 migraines, and 12 visual disturbances, and about a 1% incidence of chest pressure. And the leading theory for why this occurs is related to the gas bubbles. That is, particularly the nitrogen in air-based foam is slowly resorbed from the circulation, leading to bubbles, which can be demonstrated in virtually all patients using either echocardiography or transcranial Doppler. And for this reason, there may be potential advantages of CO2 over air-based foam. Nick Morrison did a case control study with historic controls, looking backwards at about 50 patients who were treated with air-based foam and comparing those with the larger number of patients treated with CO2-based foam. And there was indeed a significantly higher incidence of chest tightness, dry cough, and dizziness with the air-based foams. Although visual disturbances were more common with air-based foams, this didn't reach statistical significance. But is this really due to the bubbles? And the same French group had patients who had visual disturbances thoroughly evaluated both by a neurologist as well as diffusion-weighted MRI. Of the 20 patients they had with visual disturbances after sclerotherapy, half of these had a concurrent headache, which I think is consistent with most people's clinical practices. And on neurologic evaluation, this was a headache specialist who evaluated all of these patients. All of these were felt to be consistent with a migraine, and there were no ischemic lesions on MRI. And this was postulated due to the release of endothelin-1, which is well known to be associated with foam sclerosants. And I think this theory is gaining increased traction in the literature, that although you can see bubbles in all of these patients, they aren't necessarily the cause of the underlying visual disturbances. So I think this is an unresolved issue. Adverse events are rare and for the most part self-limited. Events may be more common, particularly the dry cough with air-based foams. However, there are plausible explanations other than bubbles, and I'm not sure there's enough evidence to support routinely moving to CO2-based foams. The last controversy I was going to talk about was also covered a bit in the last session, and that is the management of concurrent pelvic and lower extremity venous reflux, and in particular talking about those patients who have pelvic source varices but no pelvic symptoms, and whether the appropriate approach ought to be as described in the last talk, which was excellent, with control of proximal reflux first, which makes physiologic sense for what we do everywhere else in the venous system, or with distal sclerotherapy first, either blindly or guided by fluoroscopy. Some of the larger series now suggest that as many as 16% of women will have pelvic source of their lower extremity varices, which typically occur in the distribution of the obturator vein, giving rise to vulvar varicosities, the internal pudendal vein giving rise to these medial thigh and perineal varicosities, saphenous varicosities that can arise either from the obturator or the internal pudendal varicosities through an incompetent subterminal valve, and finally the posterior thigh varices usually arising from the gluteal veins. It's clear that if the distal varices are treated without treating the proximal source, there clearly is a higher incidence of recurrence, and this is a series from Mark Whiteley looking at recurrent varicose veins after open vein surgery. You can see particularly in the group 4, that is females with children and without a previous hysterectomy, about a third of the recurrences are due to pelvic reflux alone. So the question arises, should that be treated first, or is it enough to just wait for the recurrence? And I don't think that's answered. It's clear that pelvic reflux is an underappreciated source of varicose veins, and at least 1/3 of recurrences in women who do have a pelvic source. Recurrences are undoubtedly more common with just a distal first approach, but virtually all of these patients are going to require either a concurrent or a second procedure, as was described in the last talk, to take care of their lower extremity varices. They will very rarely be completely resolved just by treating the inflow. So I think it's unresolved whether two upfront procedures, that is treating the pelvic vein source as well as the distal varices, is better than addressing a current recurrence when it eventually does occur in at least a third of patients. Thank you very much.